This meeting is no longer being transcribed. You've been muted. To unmute yourself, press star.
Is Robin here?
Yep, I'm here.
Okay, great. All right, it looks like we have everyone. I'll call to order the Green Mountain Care Board's hearing of May 22nd, 2024. We have meeting this afternoon and this morning. This morning's agenda has two presentations: amendment to OneCare's fiscal year 24 budget and a potential vote, and then fiscal year 25 OneCare budget guidance, a staff presentation, and a potential vote. Those will be presented by Staff Attorney Mark Hengstler and Michelle Sawyer, our Health Policy Project Director. First, I'll turn to the meeting minutes from May 15th, and I will move for approval of the meeting minutes.
I'll second.
All those in favor say aye.
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 Aye. The minutes are unanimously approved. Ms. Barrett will provide the Executive Director's report.
Thank you, Mr. Chair. We have a new public comment period. Yesterday, we had a hearing on UVMMC's CON for an outpatient surgery center. We are accepting public comments until noon of May 30th of 2024. In addition, we have another open public comment period for the reporting manual on our all payer claims database, which is called VCures. And we are accepting those comments by May 31st. We also have two ongoing public comment periods on the AHEAD model, the potential next model for Vermont to participate in with CMMI. Please share any of your comments regarding that. We share those comments with our colleagues at AHS. And also an ongoing public comment period on the hospital sustainability work per Act 167 that the Green Mountain Care Board is leading. So with that, I will turn it back to you, Mr. Chair.
Thank you very much. Mr. Hengstler, do you want to provide the presentation on an amendment to OneCare's 24 budget order?
Yeah, happy to do so. Let me just pull up a couple of quick slides. This won't be long. All right, that should be showing. So I'm just going to tear through a few brief slides just to give us an overview of what we're doing this morning. And I'll explain in here how I think it would make the most sense to move through this discussion after the slides wrap up. So we're looking today at potential amendments to the OneCare Vermont FY24 budget order. A little bit of background on where this is coming from. In the budget order from this year, the last condition, condition 19, states that after notice and an opportunity to be heard, the GMCB may make such further orders as are necessary to carry out the purposes of this order and 18 VSA section 9382. On May 8th, the board moved to consider doing this, to consider two potential additions to the budget order. The first would require OneCare to prospectively include in its hospital provider contracts a method for tracking population health investments for primary care. And the second would require OneCare to track and report prospectively on its administrative expenses by function or by program. OneCare has not provided a written response yet to these motions, but it may respond at today's meeting if a vote happens today prior to doing so, or if a vote happens next week, which is also fine, then OneCare would have additional time as well. Again, condition 19 states that OneCare is entitled to an opportunity to be heard on this issue, and requires that any further orders that are included in the FY24 budget order be necessary to carry out the purposes of the order and statute. So with that in mind, I just want to go over what the statute and order have as written so that we can kind of couch ourselves in where we're at and why the board might want to act on two matters here. So starting with the first item, which is investments to strengthen primary care. Here's what the statute says. 18 VSA 9382 B1G states that the board shall review and consider the extent to which the ACO provides incentives for systemic healthcare investments to strengthen primary care, including providing resources to expand capacity in existing primary care practices. In the budget order on page 34, the board made two findings. The first was that the level of support for primary care resources proposed in OneCare's budget is vital to the goals of strengthening primary care. And second, that OneCare had declined to provide requested information about how it ensures primary care earned incentive dollars are flowing to these providers and or are being invested into primary care transformation efforts. So with those findings in mind, what the board did in the FY24 budget order was to require OneCare to provide the board verification that all OneCare population health payments presented by OneCare in its budget as incentives that support primary care were actually reaching primary care providers. That was the language of condition 17. In February, OneCare wrote to the board and explained that it wouldn't be providing this verification. It wrote that directing participating providers to expend funds in the manner contemplated by the verification or the oath is not something that the OneCare Board of Managers has felt is necessary or advisable and is not a current contractual obligation. So that's where we stood when the board met on the 8th. The idea at this point is that the board could include a new condition to try to get at this issue that it initially tried with condition 17. And I have two ways of doing this here. We can chat more about these, but I'll just explain kind of what these two different ways of doing this would basically look like. So starting point for template motion language, the board could move to amend the OneCare Vermont budget order by ordering OneCare to prospectively include in its contracts with hospital providers, first option, a method of tracking population health payments to ensure those payments strengthen the provision of primary care. So the idea here is the board would direct OneCare to include in contracts prospectively some method of tracking how this money is making it to primary care projects within the hospital network. If the language was as simple as this, it would give OneCare and hospital providers a chance to kind of figure out that method amongst themselves. The board could obviously be more directive than that, but that would be the first option, would be to ask for some method of tracking this so hospitals are tracking these items basically through contract with OneCare. The second option, which is a little bit more of a light touch, is that the board could amend the budget order by ordering OneCare to prospectively include in its contracts language stating that the hospital shall use all funds received from OneCare for primary care investment to enhance primary care initiatives, which otherwise would not be funded to the same extent. So the idea here is kind of as light a touch as possible. The OneCare would be required to have in its contracts with hospital providers language that states that hospitals are going to use the money as intended. That's what that would just be the language. It'd be part of the contract language that hospital providers and OneCare would enter into. What the board could then do is, to the extent that it wants reporting or tracking of this information from hospital providers, it could really deal with that on the hospital budget side of its work. In other words, rather than using OneCare as a means of trying to get this information, it could just require OneCare to have in its contracts this language that hospital providers are going to use the money as intended, and then any reporting efforts that we want to deal with could happen in the hospital budget process. So those are two options for dealing with that item. I'll move ahead now to the administrative budget by function, which is the second item. So 18 VSA 9382 B1D states that the board shall review and consider the character, competence, fiscal responsibility, and soundness of the ACO and its principals. A little history here. In 2021, the board contracted with Demore Health Advisors LLC to get some recommendations for how the board could regulate and work with OneCare to improve OneCare's operations. There's a big list of recommendations from Demore Health, but one of those recommendations was that OneCare should integrate a program evaluation process into its annual strategic and operational planning processes to measure program effectiveness and to identify programs for modification or elimination based on data and actual program effectiveness. That was one of the recommendations, and the board, in its budget order for fiscal year 24, tried to get at this in a relatively simple way. So what the board did was it said, okay, when OneCare submits its revised budget, it's going to use a template provided by GMCB staff, and then the template the GMCB staff created, which was the FY24 revised budget workbook, included a template for reporting OneCare's administrative budget by function. The idea was that OneCare would track its administrative budget by function. It would report on those figures in their revised budget, and then the board could see how much it cost for OneCare to fund each of its programs or functions. In February, OneCare wrote to the board and explained that it doesn't track its administrative expenses in this manner, and so would not complete the template as requested. So we didn't get this back when we got the revised budget submission. So some template language, if the board wants to try to deal with this and get what it requested in, through condition 9 of the budget order, the board could move to amend the OneCare Vermont budget order by ordering OneCare to track, starting July 1st, its administrative and operational expenses by function, such that OneCare and the board can sufficiently identify the administrative and operational expenses of various OneCare programs. OneCare shall track these expenses using the functions outlined in the FY25 budget guidance workbook, which shall report on the FY24 actuals in its FY25 budget submission. So a few quick notes here. The template motion language states that this would start on July 1st, not because we've talked with OneCare and have decided and have gotten confirmation that this is a feasible date from them, but it states that because July through the October submission would give the board roughly a quarter of actual data if this was the deadline. So just from a data perspective, starting July would give us 3 months, which is a pretty, it's kind of the best that we could imagine doing at this point, as far as I can tell. OneCare might have some reasons that this wouldn't work. Would be happy to hear those. The idea here is that if OneCare is reporting on some actuals for FY24 when it submits its FY25 budget, the board and OneCare will have really a better way of actually evaluating the budgeted administrative costs by function for FY25. So it would have been better to have this data going back earlier into 2024. We are not asking OneCare in this template motion language to go back retroactively and try to get this data. That doesn't really make sense if the goal is to get, for example, administrative time records of how time at the staff level at OneCare is being used. So the language here is just intended to prospectively give us something for FY24 that we can look at for FY25 budget submission. So with that, that's the template motion language for item 1 and item 2. I'm going to take this off of the screen for a moment, and I'll turn it back to you, Chair Foster. OneCare certainly has the right to share any thoughts about this. And I think that one option is OneCare could just do that first as a starting point, and then we could turn to board questions. Or if you prefer, we could do board questions first and then turn it to OneCare. I think either would work.
Thank you very much, Mark. That was helpful and a really good history of that. So thank you. I'm happy to hear from OneCare folks. I see a couple are here. It might inform board members a little bit better if we hear from OneCare first, if they were interested in doing so. And sorry, Mr. Hengsler, one other question. You said we don't have to vote on this today, is that right?
Yeah, so we're noticed for a potential vote today and a potential vote for next week. So there's flexibility in the schedule to do this either way.
Okay, great. So just to the OneCare folks that are here, if you want to comment now, please do. If you want to take a couple days and send in a written public comment or something, that's fine, since we don't have to vote today, and you don't have to comment if you don't want to. So I'll turn it over if you'd like to, but no pressure either way. Mr. Boris, how are you? Go ahead.
I'm doing well, thanks. How are you?
I'm really well, thank you.
Great. I think I'll start with the first one and then kind of pause and get into the second one. So, Mark, thank you for that explanation. I think that was really fair, and I appreciate it. Regarding the idea of putting into contract some sort of a tracking methodology prospectively, understand where it's coming from. I just want to kind of echo the concept of asking for this information in the hospital process. I think that makes a lot of sense to me. Just for my work with the hospitals, I think they're all doing really amazing things in this space and investing wisely in their care delivery and expanding what is defined as primary care. And I think that their explanations of what they're doing in their own organizations will be more valuable than any kind of tracking that we can supply. I think we could help get some sort of a, here's a page of numbers and, maybe an attestation, but I think the story is more important to really show the work that we're doing together with our provider partners. So just want to really kind of echo, I think that would be a really effective way to understand how the healthcare system is evolving with the resources, many of which come from the hospitals themselves, are being put to good use.
Thank you. Mr. Berman?
Hi, Abe Berman, CEO, OneCare Vermont. Just adding on to what Tom stated, appreciate the board considering some of the feedback we've provided. I think doing this on a prospective basis in our contracts makes sense. I think Mark did a nice job outlining a possible process you could take to do that. I agree with Tom that it makes a lot of sense to have it come from the hospitals. I don't think you'll have any resistance from the hospitals in describing how they use those funds. I think they do a good job tracking them as well. But I do agree with that second approach that it should largely be part of the hospital regulation process for the Green Mountain Care Board to get that information. The one thing I did want to comment on is there's a subtle shift in language between what was in last year's budget orders to what's here, and that the dollars may not flow directly to a primary care provider. They may be in support of primary care, the way these organizations are using the funds. And I think that's expressed in the latter language, but wasn't always consistently expressed. So I just want to be clear, in support of primary care doesn't necessarily mean it goes into the salary of a primary care provider. There's a lot of other things that I think can happen with that funding that are really valuable to support primary care.
Thank you. Mr. Perry.
Yeah, I think on that issue, I agree with what Tom and Abe both said. And Mr. Chair, you offered an opportunity for us to maybe be able to have a couple days to provide a written response. I think from a legal perspective, we'd want to run through our contractual obligations that we have to our payers and make sure that whatever gets implemented and we agree works doesn't violate those or put us at cross purposes with some of what those say. And we're going to need some time to put that together to make sure that everything is sound.
Okay, great. I think that's prudent, and we don't have a pressure to vote today, so I'm happy to put off the vote so that you can have a chance to do that. And I was reminded while we were speaking to identify people if they're associated with a regulated entity. And just so for the record and others, Mr. Perry is, I believe, the general counsel at OneCare, and Mr. Boris is the CFO, I believe. Great. Okay.
That's correct. Thank
Any
you.
board? Thanks. Any board member comments or discussion?
I was wondering if, and maybe this is something we would do with the template in the 25 guidance, but in terms of the admin function question, if we're going to discuss that today, I had some questions about the categories and the template. I don't know if you want to do that in this part or the next part, but they're linked to me in my mind in terms of the modification of the fiscal year 24 budget around budget by function.
Yeah, same. We can, why don't we wait and do the next part since they are kind of related and it might be better to have the whole set of information. Mr. Boris?
Sorry, I might be raising my hand at the wrong moment, so I apologize if that's the case, but I do have a couple comments about the administrative budget by function and the language here. So if it's appropriate, happy to make them now. If you'd like me to pause, that's fine too.
No, please go ahead.
All right. So this one's admittedly piddly, but I still feel obligated to say it. On slide 5, it says we would not complete this template as requested. I think a more correct way of stating that is to say we couldn't. We just did not have historical data, so it's not an unwillingness, it's just an inability to do that retrospectively. On the time tracking or the budget by function, it's largely a time tracking exercise for staff. So I've kind of two thoughts. One that's kind of logistical and one that's conceptual, I suppose. One is around timing. We build our budget largely in July and August. And then it goes through our board for a couple different passes. We typically do a preliminary look in August and then a final look in September. And then their approval, paves the way for us to submit all the documents on October 1st on a regularly scheduled timeline. So all this is to say, our budget will be underway and being built up over the next couple of months. So if we were to do start a time tracking process with all OneCare staff, it's going to be much less than a full quarter of data that we'll be able to capture. We're really talking a couple of weeks, maybe a month of reliable data. But the bigger issue is actually that our work really flows on an annual cycle. This is what I say to new people that are hired into OneCare. You really won't understand the business until we've traveled around the sun one full time, because there's certain bodies of work that'll happen heavily in the fall, and you really won't touch them until you get to the next fall and have a chance to do it again. So if we do a short-term time study, I think it will be an incomplete picture of the work that we do. And, for example, the budget build is very heavy in the summer. It's not something that we engage in heavily, thereafter. We go through the testimony and all that, but the actual budget build process is periodic. And, a lot of the other work that is linked back to something like the contracting process for, the longitudinal care program, for example, it's very intensive for a period of time. And then once we get into kind of the ordinary operations of that initiative, could be much quieter. So all this is to say is to get a really accurate picture of OneCare's work and how the different administrative functions support all these initiatives that we run and fulfilling our contractual obligations. A longer term time tracking initiative is strongly recommended from a technical or logistical standpoint, which leads to my second kind of conceptual thought here is to do this time tracking in a reliable way that we would feel good about. Like, I can endorse it in a budget, and I think it would be useful to you as a regulator. It's asking our staff to track their time for a full year. And that's really penalizing to them. They come to work to do all these altruistic things and try and help the healthcare system as much as we can with the few resources that we have. And I think the burden on them to do that would just be really disheartening. And I'd like to see us try to work together to figure out a different way to meet this objective so that you have what you need and we don't ask our staff to track at a very microscopic level with each of these little categories how they're spending their days. It's tough enough to work at OneCare, and I think that this would be a really hard thing for the staff to deal with.
I have one question, if you don't mind engaging on this a little bit. So I think the purpose, I mean, I appreciate those points. And I'm a practicing lawyer too. And when I do that kind of work, I've got 6-minute increments I got to live with and describe every phone call and every email I write. And it is not the favorite part of my chosen profession. So I appreciate the challenge of that, and it's not a lot of fun. But what we're trying to get at is, the OneCare budget's been 13 to 15 million-ish for several years. And there's a concern, at least on the board side, that maybe not all that expenditure is having the impact we want. And so we don't want to authorize spending of state money, ultimately likely commercial money, on programs that might not be having the return we hope. And I fully recognize some of them are very, very difficult to even try to measure, as you know, from our effort at the ROI analysis. So how would you propose we best get at understanding what costs are not having a positive impact on Vermont quality, access, or costs?
Sure, I could take a stab. First, we're privately funded by hospitals, and money is fungible. It's just technically incorrect to say that we're state funded. Don't want to get in that argument right now, but we are privately funded. I think to get at that, it's a zoom out. The work that we do is highly matrixed within our organization, and everything that we do is in spirit of just ensuring that we can function. All of our work is contractually bound. We have contracts with payers, we have contracts with providers, and we just need to fulfill all those expectations, or we get dinged in our financial statement audit, or our customers, the providers, won't sign up anymore. So it's a constant assessment that we make internally and with our board and governance. Do we have the right resources to fulfill all the expectations of those contracts and ensure that we can operate in a reasonable way and in a responsible way? We deal with a lot of money, a lot of financial risk, and we have to have resources to do that appropriately. Otherwise, I think it would be irresponsible of us to offer these risk-based programs without enough administrative support for the provider network. So I think the answer is actually a zoom out question of asking whether or not there's a belief that ACOs are a positive influence on the healthcare system. And the budget that we build is designed to support the work we have in front of us. And you can't just cut off an arm of it and expect the whole thing to keep working. I can promise you that. But I believe, and I think our entire executive team and our staff all believe, that the work that we are doing is beneficial to the parties we have business with, which is payers and providers, and that work will benefit the healthcare system broadly, which affects us all in a really positive way. Measuring that, admittedly, really difficult to do. I mean, it's hard to, I don't know which Vermonters are specifically referenced in some of the documents, but really we work to serve our providers so that they can do better serving their customers. And I think to answer that question, it's actually, let's zoom out and talk about ACOs and what we can do as a system, rather than digging in to segment the business and cut it into different parts and seeing which ones can be lobbed off.
Yeah, and just on your first comment, privately funded, what I was referring to was really most of the money, if not all of it at this point, comes from hospital dues. And hospitals tell us that Medicare and Medicaid don't pay enough, and all the excess money comes from commercial. And so I said Vermonters' money, I meant either through taxes or commercial health insurance through the hospital's funds OneCare. I get that it's privately funded, but it's public money that goes to a nonprofit that then goes to OneCare. Okay, well, I appreciate those comments and thoughts. Any board member comments or thoughts at this time, or we can take it up in the next part?
Right.
All right.
I just
great.
have
Thank you.
one.
And if you have, I was going to say, if you have stuff that you want to put in on this, I don't think we need to vote on this today either. So if you wanted to add this to any sort of letter to provide the board more feedback on this point, certainly open to it. Go ahead, Dr. Bergman.
Yeah, I think that what I'm struggling with is that I think that you're suggesting that our trying to understand time allocation is too granular, we need to step back and look at what are ACOs for? You know, let's have that discussion. I think we're actually somewhere in the middle. We're trying to figure out what are the relative benefits of the various programs within the ACO, not with an intention to cut an arm or a leg off, but to figure out what's working well to try to emphasize for future projects within Vermont, and what does it cost to run those projects? And, you know, the possibility that OneCare is in a very different configuration in a couple of years, and some of those projects may need to be taken over by other entities in one shape or form. So yes, I think we would, you know, you offered, you know, to try to have a conversation, try to figure out how we can get to that. And I think that's what we're trying to get to. And I think we've been trying to get to that for a while. So if you have ideas about how we can think about the various components of the organization, where they could live in the future, what might be okay to sunset, what would be great to continue, and what are the relative benefits of those things? Because, you know, the all-payer model is not going to continue in its current form. OneCare is going to look different, and there are, you know, there's things that I think we hear over and over again we want to make sure survive. So I think that's the intent of this. It's not, you know, it's not intended to burden the staff of OneCare, who I'm sure go to work every day trying to make healthcare in Vermont better for everybody. I truly believe that. I think, you know, that is the goal, but it's for us to try to understand. And if you can help inform us in this in a different way that satisfies, I think, our desire to understand what is working and what should we try to continue. I'm open to other approaches, but to just simply say we need to look back at the very, very broad thing, I think it misses, I think, where the board has been trying to get to over the last few years.
I can just actually add a little bit to that. It might be helpful in the next week. I know you're going to be preparing some comments, you know, with reference to these motions. It might be helpful to hear from OneCare about the categories that have been proposed to do the tracking, and, you know, balancing the administrative burden of doing that time tracking against what the board is trying to seek, which is a better understanding of resource allocation. I'm wondering if part of your comments might be a look at those categories and trying to balance that and give us some suggestions for other categories, or another way to think about how time, you know, and other resources are spent across the programs to get at closer to the program evaluation that, you know, I think people have been seeking. So I just would ask for that if you have some suggestions.
Mr. Berman.
That's really helpful, Dr. Merman and Member Holmes, context, and I think we can do that in written feedback. Just a little bit of sort of nuance to it. So, for example, we spend a couple $1 million of our budget on data informatics. Some of that is going to be allocated to each one of the projects that are in that list. But in fact, we can't take out a piece of that $2 million because we stopped doing that project. We have to keep the data secure, and we have to keep access to it to do a lot of that work. So it's sort of like a fixed component that's not able to be scalable necessarily to that work. So I think what we can provide in our response is that there are some things that are like that, where in order to operate an ACO, you have to keep data secure. You have to have a platform to issue data on it. Now, you could argue we don't have the right platform, it's right there at cost, but the way we are right now, we couldn't necessarily scale that back easily. But we can point out to you, like, hey, here's areas where we have direct labor that goes to direct efforts. But I think what Tom's saying is it is pretty labor intensive to do that at a highly detailed way. We'd be happy to come back to you with some like categories that we think make sense in a way to look at these programs. But the ROI itself of each individual program, we look at really closely, and we don't engage in efforts. And in fact, you know, prior to my term with OneCare of the past 14 months, have stopped doing many things over time and started doing other things. But you know, there are programs like CPR that have been very well received, and you've gotten numerous amounts of feedback saying they're good programs. It may be hard for us to sort of parse out and say, here's how much it would cost to operate CPR as a standalone entity, because I think that's what Dr. Merman was referring to. Like, if OneCare to stop doing that program and you wanted to keep doing it, how much would it cost to run that? We can tell you, here are the things that you need to do in order to run that program, but it might be hard for us to say this is exactly how much it costs us to run it. So maybe there's a balance somewhere in the middle. We can tell you, here are the things that we think go into each one of these programs. And here are some of the fixed things that the ACO has that we think you have to do a risk arrangement and to offer services like this. But getting down to the granularity of it's 11% of our budget to run this program and 3% of our budget to run that one. That's where we're a little bit more concerned of assigning direct costs. Typically, when this rage happened in healthcare, people would do time studies to do time-driven activity-based costing on very granular, small things. So, for example, we're going to look at one area of lab and one particular test and see how much that costs. But to do it broadly became overwhelming. So they decided, you know what, we'll only look at discrete processes and try to assign costs that way. All that is a lot of words to say, we want to work with you to get where you want to go. It's just, we're trying to be honest about how much effort that will take away from other stuff that we want to do because we have a finite amount of labor and time to do it. And, I think, Chair Foster, you sort of brought up the 6-minute increments. I used to bill in 15-minute increments when I was in public accounting, so I totally understand that. But that was largely a function of how I got paid. Like, the firm got paid based on my time. That's not really how the ACO currently receives revenue. So it's not really a requirement to get paid necessarily. It's really to meet this obligation. So I'm trying to find a way that's lower administrative burden to do that and to give you the information you want. So anyway, that's just my 2 cents on it.
Thank you. Yeah, and we also, use that kind of time to track what kind of resources we're putting on different matters, not just to get paid, but how are we allocating to different matters. So, I'm not an accountant, but that's how we do it. Why don't we keep going? I see Tom Walsh, but this is helpful, and we're trying to be collaborative to make this work in a way that is responsive to your realities, but also our needs of protecting the spend on things to make sure that it's being productive. So we appreciate your feedback and trying to find a path that can make this work for the board's regulatory needs. And thank you for doing that. So I'll go to Tom Walsh, then we'll move on because people have some hard stops. You okay, Tom?
Yeah, it's fine to move on. You hit on what I was going to say.
Great. Okay, we'll turn to, thank you for the feedback, and we'll go to Michelle Sawyer.
Great, thank you. So a somewhat related topic is the FY25 budget guidance for OneCare. We're here to review some proposed changes from the FY24 guidance, and there is a potential vote noticed. So we did have a public comment period open from May 15th through the 20th, but we did not receive any public comment to date. Here is the timeline for this process from basically now through the end of the year. The ACO budget guidance is released by July 1st of each year. Because of the timing of other board processes, we were able to move up the consideration and potentially the issuance of the FY25 budget guidance sooner. The certification materials and the Medicare only ACO guidance will likely be issued closer to July 1st. The budget submission is still due October 1st, so that has not changed. And the board, as every year is the case, must vote on all ACO budgets by December 31st. So I wanted to walk everyone through the staff process for the development of this guidance. Following the FY24 budget vote, the staff held meetings in January to gather board feedback regarding the FY24 guidance and the budget process while it was still fresh on everyone's mind. There was a general consensus that many questions could be removed from the narrative as they either resulted in duplicative or less helpful information, or some others could be removed as they were better addressed during a hearing that would allow for better dialogue between parties. Second, we cross-referenced the guidance with Rule 5.403 and 18 BSA 9382 to ensure that we weren't removing any required questions or appendices mistakenly. We went through and cited every remaining question within the guidance narrative to the applicable section in the rule and statute. Third, we asked both the Office of the Healthcare Advocate and OneCare to review the drafted budget guidance materials and provide feedback. So here are the goals overall for 2025 guidance. First, we're really looking for the right information in the right format. And that looks like paring down information that's really closely linked to what is in statute. We also recreated tables that OneCare had provided to us previously in their narrative, and put those into the workbook instead, so there could just be an easier analysis. We eliminated appendices that were not tightly tied to requirements of the budget consideration. And then second, we eliminated questions that the board had agreed resulted in less helpful answered or were better suited for a hearing or a discussion, and in an effort to reduce the administrative burden. I know that is something that is on all of our minds right now. And then lastly, and perhaps most importantly, or notably at the very least, we really focused this guidance on the future. So we phrased a lot of questions to elicit answers that are forward-looking to what is next for the ACO and what's next for the Vermont and healthcare reform. We did retain a lot of questions focused around lessons learned from past and current programs so that these lessons can be applied to the future. I wanted to share this one paragraph from the introduction section of the guidance, as I felt that it really summarizes what the board is looking for within the ACO's FY25 budget submission. So recognizing the business year 2025 is the final year of this ACO payment model, the GMCB is focusing the budget guidance on ensuring appropriate final year ACO costs that reflect the value to Vermonters of the ACO, ensuring sufficient oversight of the ACO, and reporting data and information that will assist in future efforts while reducing reporting that will no longer be useful. As such, the approach to the guidance is to suggest the ACO minimize costs to support only programs shown to yield positive financial returns for Vermonters, and to finish out this model while freeing up resources to be deployed for future purposes. All right, so part one of the guidance is around budget targets. As laid out in rule, the board has the authority to set benchmarks, or as we call them here, targets, to signal to the ACO what the board would like to see in their budget submission. Targets are not binding. The ACO may not meet a target, but must explain and justify that choice to the board. If the ACO does meet a target, they can expect less scrutiny in that particular area of their submission. So let's walk through what has changed between last year's budget targets and this year's. So the first is that the commercial benchmark trend rates must be consistent with the ACO attributed population and the GMCB approved rate filings. We are keeping that target unchanged for this year. There had been a target around FPP goals, and because the movement in the achievement of fixed perspective payment in the commercial payer arena has really been stagnant for some number of years, we did remove that goal, and we really didn't feel like it was tightly tied to statute or rule. The next is that last year we had a target around the ACO holding Medicare Advanced Shared Savings dollars as risk. And I do have an asterisk just noting that while they didn't do that in their budget submission, the board chose to slightly modify that in the budget order, having them hold those dollars at risk, as well as an increased dollar amount that we'll talk about next. So what we decided for 2025 is that the ACO should have discretion to hold or disperse risk to their network as they see fit. The logic here is that, it looks like global budgets are a very real possibility for the future, and that hospitals, if that comes to be, will be holding a large amount of risk, and that to shield them from that at this point doesn't make a whole lot of sense. In 2024, there was a budget target encouraging the ACO to increase all of their risk corridors. This was not met in their budget submission, but the board ordered OneCare to increase the risk corridor in the Medicare payer program by 1% and to hold that 1% at the entity level. The change for FY25 is that OneCare may drop that extra 1%, but they have to maintain at least the FY23 corridors for FY25 among their public payers. In the next iteration of the all-payer model extension, there is an option for an asymmetric risk corridor, and the budget target allows for the ACO to choose that path as well, should they so choose. Next one is the ratio of operating expenses to PHM payments should be less than or equal to the 5-year average. We just simplified it a little bit. The ratio should be less than or equal to the FY24 amount. Next, there were placeholders for 2 targets regarding executive compensation that didn't end up coming to be, so we did remove those. The next is the ratio of operating expenses to attributed lives should be at the prior year minimum, and we did carry that forward for 2025. And the performance improvement plan for 3 metrics based on performance in the Medicare ACO performance benchmarking report. So OneCare was to choose 3 metrics that there was room for improvement on and really focus on that. And we have not changed that for 2025 guidance, and we are encouraging them to keep the same 3 areas of focus because we understand it takes more than 1 program year to really make a large impact on these things. There are a handful of new proposed budget targets for 2025. First, being the ACO's administrative budget should not include expenses associated with programs not demonstrated to yield positive financial results for Vermonters. It should only include programs necessary and resources necessary for it to satisfy the all-payer model requirements. Next, should the ACO choose to participate as a Medicare Shared Savings Program ACO in FY25 and leave Vermont's all-payer accountable care organization model agreement, OneCare must submit a new budget that reflects the fact that its value to the state is more limited and must provide any and all additional information as requested by the board. And lastly, whether under the APM or MSSP, the ACO must account for its administrative budget by providing a breakout of the budget by function. All right, that wraps up the targets. So part 2 of the guidance has several sections, and we'll just walk through. I'll try to be as brief as I can, but these slides do get rather wordy. So the executive summary, we're really focusing on network and programmatic changes from FY24 and lessons for the future. So previously, we've asked to kind of summarize your budget, summarize your programs, much like an executive summary might be, to reduce the amount of writing and explanation needed. We really just want to hear about changes. We have several years under our belt working with OneCare, and we have a pretty solid idea of a lot of their, how they budget, how their programs work. Just tell us what's changed. And then that last bullet focuses on a description of any lessons that they've learned through programmatic evaluation and how they will influence the ACO's programs in the budget year and beyond the budget year. Section 2 is provider contracts. We are continuing to collect data regarding the ACO network participation. It's largely unchanged, the rationale being that having an accurate count and a picture of statewide engagement with the ACO through the last year of the all-payer model is useful for any future analyses. Section 3 is payer contracts. Again, we're trying to pare things down, really focusing on new payer contracts and any changes to current contracts. So scale and program alignment forms are previously required every year for each payer program, and now are only required for any new payer programs. However, we will collect a copy of all contracts just to have, if we need to check anything, have that reference. We have asked for just a narrative description of any new contracts, changes made to continuing contracts, and explanations for terminated contracts. There were several questions removed from this section as we found that they didn't really tie tightly to requirements in statute and rule, and we felt in our efforts to pare things down, these ones could just be let go. So we removed questions around fixed prospective payment targets, work with Medicare Advantage plans, work on risk-bearing commercial plans, and the global payment pilot with DIVA. And I'll just note that, after we get the budget submission, we can always ask follow-up questions if we didn't get the information that we needed. Section 4, total cost of care. We are continuing to collect this type of data through the workbook, but with less narrative. So Appendix 4.1 is unchanged. And Appendix 4.2 is also unchanged, but we did shorten up the narrative that goes along with that appendix. And we removed narrative questions around drivers and assumptions for total cost of care and descriptions of adjustment factors for settlements. Section 5, programs and risk. We are looking for less granular risk data, but slightly more granular network settlement data in a way. We tied descriptions of programs, so we asked for descriptions of their programs, but we used more direct language pulled from the rule to just make sure that that's what we're focusing on. The Appendix 5.1 ACO risk by payer was previously collected both at the payer level and then at the HSA. So we had risk by payer for the hospital, for non-hospital primary care, and hospital primary care for every HSA. And we just felt like that level was no longer necessary. So this particular appendix will collect ACO risk by payer held by OneCare and by their network, and we don't get any more into the weeds than that. There is a new Appendix 5.2. This particular appendix was a follow-up question that we had sent to OneCare last year after they submitted their budget, so we felt it prudent to just include it up front this time. It is a projected 2024 settlement. What do they anticipate going back or coming from the accountability pool, which is really the primary care risk mechanism, versus settlement for the hospitals? And we removed narrative descriptions of provider payment strategies and methodologies, risk model and stratification methodology, and we did remove the old Appendix 5.2 because when we removed the HSA level data, we found that what was left was duplicative of other appendices that we already collected. Section 6 is the financial budget section. There are new appendices per the budget order, but there is less narrative overall. We added Appendix 6.9, which collects a history of OneCare's net assets year over year. This ties back to a budget order condition in their FY24 budget order. We added Appendix 6.10, a budget by function and program. There has been some modification to this since what we sent to OneCare as part of their revised budget. We did receive from OneCare what they recommended for categories, and we are definitely very open to finding some middle ground here and something that works for all of us, serves the needs of the board, and reduces administrative burden. So there may need to be some more work on this. And I'm happy to share at the end if board members have questions about its current status, maybe we can look at it. We did remove narrative descriptions of adaptive and workbook submissions, and we reserved just descriptions of what changed between 24 and 25. And a note on adaptive, we're no longer requiring OneCare to submit their financial statements in adaptive. They requested that they just submit it using Excel, and we have no problem with that. We removed narrative questions around executive compensation benchmarking methods. We have that information now, but we will continue to collect that data in an appendix. One note about that is that we did remove director level positions from that appendix. So it's, C-suite and vice president, but we will collect salary data, the benchmark, the applicable benchmarks, and the variable pay. And then we moved the request for the Form 990 to the reporting manual as we felt as though the timing of the budget submission really just didn't make the most sense to include that as part of the guidance. Okay, and then section 7 was the quality, population health, and model of care section. So we're really focusing on changes between the program years and lessons learned for the future. So the model of care, we're reframing to focus on changes, lessons learned for the future. We combined the questions around clinical focus areas with the quality improvement questions. And we're focusing on KPI performance. Before, we had asked a lot about how they're performing on their PHM measures, but we find, we can get that information through their board of managers meetings, and we don't need them to provide that information if we are able to access it ourselves. And we removed some questions and appendices around care coordination, integration of social services, primary care incentive funds, and the public health emergency, again, because we felt as though in our efforts to streamline things, they weren't tightly tied to statute or rule, and we could simply do without. Section 8 is performance benchmarking, continued focus here on ACO improvement activities. We trimmed down questions to focus on network surveys the ACO is conducting in 2024 and what they're planning for 2025 and how they're improving those survey practices and how they are improving their evaluation of their population health management programs. Any note of the ROI is moved to the reporting manual. And regarding the Medicare ACO benchmarking report, we have the same question as last year. How is the ACO working to improve performance on those 3 metrics of focus as we saw in their budget submission for FY24? And the last section is around the all-payer model. We eliminated Appendix 9.1 as the staff had not found this information to be directly informative of the board's decision-making process. However, there is a single question that remains to keep a pulse on OneCare's efforts to align its priorities with the all-payer model extension. Part 3 is just a little blurb, and it's 1 page, less than 1 page, and it just describes the revised budget process. It's not a required part of the guidance. So I wanted to invite the board to consider doing something different with this in the budget guidance this year. And so these are kind of 3 proposals that I have. We could certainly just keep it the same. We could do our best to come up with a description or even keep the description that we have of the revised budget in there as it has appeared for the last several years. It's basically a copy of what has appeared in budget order conditions relating to the revised budget year over year. So we could keep it the same. We could consider modifying it. Some ideas, given the process that we all just went through a couple of weeks ago, we could look at saying the revised budget isn't necessary unless there's a certain threshold is met with a change in attribution. We could delegate the determination of the usefulness of a revised budget process to GMCB staff. We could create language that allows the ACO to specifically request waiver or a modification of these requirements. And I'm sure there are other ideas for modifying it as well. And the other thing you could consider today is eliminating this particular really just paragraph from the guidance, and we could just address it through the budget order in December when we've gotten their initial budget submission. And this revised budget language is not binding, and so if we want a budget order condition outlining the revised budget process, we can just put it in the budget order later this year. So, summary of the work done, we've worked to really balance administrative burden as much as we can with statutory requirements and interests of the board. We updated the timeline for the budget guidance issuance. We were looking at the right questions in the right format, culling of all the questions that were duplicative, and then changes in future focus, what's changed since 2024 and what What have we learned for the future? And I do have, proposed motion language should the board decide to vote today, but at this point, I will hand it back to you, Chair Foster.
Thank you very much. That's really helpful, and you did a great job with the guidance and balancing all of the needs and contexts that we're in this year. So thank you very much for you and Angela. I'll turn it over to the board for any questions or comments.
I have a couple, but I don't need to go first if somebody else would like to jump in.
Go first, you're up.
All right. On the new budget condition related to the admin budget, the way the language in the slides reads is admin budget should not include expenses associated with programs not, yes, thank you. Much better than me reading it out loud. Demonstrated to yield positive financial results for Vermonters. I am wondering if folks would be open to broadening it beyond financial. So for example, if there's a quality improvement, that would be something that I would be interested in supporting, not just total cost of care. And then the other question I had is how we're going to kind of evaluate this, because for example, I don't think I would say today that something that I think is a really good program and should continue, like CPR, has demonstrated positive financial results for Vermonters. I would say it's demonstrated positive financial results for primary care providers, which is something I want to support, but I don't feel like you can necessarily track that directly back to Vermonters. So, and I don't think the intent, I know everyone is quite supportive of CPR. So for using that just as the example, I'm just concerned that it might be a little too narrow to include things that there may be a majority of the board that still wants to support it with administrative support. So that was a suggestion I was going to make, is could we look at broadening that language a little bit? And the other, so that's one comment. The second comment is I like the idea of doing something different with the revised budget process. I would be fine, coming up with a threshold or delegating that to staff to make a recommendation, or eliminating it and dealing with it later. So I liked those ideas. I don't feel wedded to any particular version. And then my third comment was just given the discussion and the input we're expecting on the admin by budget, if we do vote today, which I'm happy to do if others are ready, it would be for me with the understanding that the tab with the categories would need to reflect our future decision around the 24 budget order. So I'm not exactly, we'll have to kind of work on the motion language to reflect that. So those are my three thoughts.
I can pop in. Interesting. I had the exact same two slides, Robin, as you, if Ari's interested. And I think on my first pass through, the term financial didn't grab me when I read them, but definitely today I agree. I think we need to think about the language on that a little bit more. I think the financial results for Vermonters, I think the CPR program is an example of that. I do think also, case management services for people in Vermont. It just gets, these things can get really super hard to quantify financially. So I guess but I guess I'm gonna stop there. I just think I need to think a little bit about how to nuance that so that we can define maybe the positive results, even if they aren't financial in some meaningful way. But let me think more about that. Regarding slide 20, in the revised budget, can we pull that back up again real quick? I think, Michelle, I like the idea of, I don't really feel confident in defining a percentage between now and when we vote on this guidance. So either delegating it for determination of usefulness, or when we do the budget order in December, defining that a little bit more clearly. I think that there's known avenues for the HPO to request waivers or modifications. So I don't know if we need to call that out specifically here. That was just my comments on this. So I guess I would sort of go through either delegate or just sort of write this into the I think we may have a lot more understanding of the relevance of this in December than we do now, especially given sort of where everything is in flux. So I'd be comfortable with putting that later on. That's it.
I think you're going to hear a theme here, but I would agree with the language change around financial benefit. I think we have to think through what that means. I'm even just thinking about data and analytics. How do you quantify the value of that? And we know it's valuable. So I think we just need to change that language. I would punt, I think, on the revised budget language in here. I like the idea of delegating to staff. The ACO has quarterly reporting, and has reporting maybe even more frequently than that, I have to remember. But the staff can always look for material changes and bring them to the attention of the board if we need to, look for adjustments to the budget or ask some questions. And I also think we have another pass at this, as others have said, in the hospital budget process. In the budget approval process in December. So I think my gut would be to remove it from this guidance and think through that either that delegation or we might look at it again in December. But I just actually wanted to say more broadly, I really appreciate the effort here to streamline this guidance and to align it better with our statute. And I do think these are the right questions. So I really appreciate the staff's work here.
I'd like to follow up with that and thank you, Michelle, and the rest of the staff for looking at our own work critically and seeing how we can improve. And I'll join the chorus. I think the language about financial impact for Vermonters is something that we need to think more about. And I think that language may change over the life of an ACO, right? Because dollars meant for transformation efforts in the first years of an organization may not lead to financial benefit or financial dollars spent on something like data analytics or transformation may not seem that benefit may not show up for some time, but 8 years in to a model, we ought to be seeing some trends toward the transformation actually occurring and outcomes that matter to Vermonters actually improving. If we're 7, 8, 9, 10 years into a model and we're not seeing that, then we as regulators need to question whether that money is actually being well spent. So understanding that there can be a period of investment where the return doesn't show up quite so soon. Secondly, I am in favor of delegating to staff, keeping an eye on things and bringing it to our attention. But I don't see the delegation or a review later in the year as either or. I think it would be both, right? The delegation is flag it for us to review sooner, but yes, we are going to review it later.
I am in accord with the other board members' comments on the opportunities to improve some of the language. So thank you. We can get some feedback on that and see if we can work on it. Any public comment? Mr. Boris?
Hello again. The first and probably most important sentiment I'd like to express is gratitude. Thank you to the staff for just hearing us a little bit about the challenges that we've had with the budget and really trying to evolve to look towards the future. Very much appreciated. Thank you also specifically for allowing us to submit our budget in Excel rather than Adaptive. I think that'll create efficiencies for everybody. So just want to express my thanks to the staff for that. A couple technical ones on slide 8, I think it was, around the risk corridors. I recommend the language is amended to reference the public payer programs. And because commercials are negotiated, having a specific target in there, may not be agreeable to the counterparty. And in fact, in 2023, we had a fairly different risk arrangement with some of our commercials. So I think making that specific to public payers would increase the likelihood that we can satisfy the order and keep our commercial programs up and running. So first comment. Let's see. Next, I'll just echo many of the sentiments expressed by board members around slide 10 and the language around the administrative budget, not including expenses, not demonstrated to yield positive results for Vermonters. I appreciate the spirit of this. What I ask for or hope that we can find is some sort of a clearer standard of measuring this so it's more objective. Either we fulfilled the obligation or we didn't. And I think based on all the comments made thus far, it'll be unclear in our budget process whether or not we've satisfied this. We would certainly be there saying we believe everything that we do is in spirit of improving results, whether financial or otherwise, for Vermonters, but it's difficult if it's not clear how that will be measured. And then last one on the revised budget, I'll put some thought into this too, and perhaps in our written comment back, we can, depending if a vote happens today, we can think about how to make that work efficiently for everybody. And there's an interesting history around the revised budget that members Holmes and Lunge might remember, that early on, when we were first kind of endeavoring in this regulatory space, it was challenging because our budget was built largely on estimates. It still is to a large degree. So we really offered to come back in the spring and say, how about we come and show you how things varied or changed, and it got coined a revised budget. I think there's value in doing that for transparency and helping you as a regulator understand, here's what we estimated would happen, and then here's the result of negotiations and attribution and total cost of care processes, et cetera. So just thought that historical context might be useful, because I do think there's some value here, but if we can figure out how to make it work efficiently and effectively for everybody, I think it will serve us all well. So thank you.
Great, thank you. Mr. Davis?
Thank you, Mr. Chairman. I've got comments that go about 3 minutes. I've got a stopwatch. I'll cut myself off. I want to look at just I think we've completely lost sight here of the basic history of what's going on here. OneCare Vermont is an ACO that when the ACO was authorized in the 2010 Obamacare legislation that passed in the federal government, the basic purpose of that legislation is to move from fee-for-service reimbursement to capitated reimbursement, and that is going to would save about 1/3 of the total cost. It was passed in 2010. We started moving on it in about 2013, 2014. Okay, and we called it the all-payer waiver, the OneCare whatever, or the all-payer model, which wasn't really one payer, but it was close. And so what actually happened over a 10-year period was actually nothing. The reason was that while that neither Blue Cross or no other insurance companies nor the federal government would allow any system, okay, apply capitation to Medicare. They just wouldn't do it. They would have prospective reimbursement, but they would not allow you to stick with it. It was a shadow calculation, and you had to change it back to fee-for-service later in the year. And so what happened is that there was no question about the purpose. The federal government in the mid-teens set up a system that said that any system in any state in the United States could move to where they wanted them to be in 4 steps. The 4th step was full capitation. Step 1 was full fee-for-service. Vermont, what OneCare Vermont has done, okay, has set up machinery that permits capitation, but nobody is going to use it. The second thing I want to point out is, why is that? Why do you suppose nobody would? And why do you suppose nobody in this whole system in Vermont wants to even talk about the whole problem of what's going on in the system beyond UVMMC? The reality is that neither you folks nor the feds have any stomach at all for dealing with the political blowback that will come from rationalizing a system that has 14 full service hospitals. The data shows that the average daily census in one of those is 1, and the idea of doing complicated stuff, heavy surgeries, including not just joint replacement, but stuff like back spinal surgeries, including different really complicated kinds of stuff like that. The reason that is happening is because the small hospitals, the non-academic medical centers, the non-Dartmouth Hitchcocks, and the non-UVMs, and the normal big players, the reason they're doing that stuff, which they shouldn't do, okay, is because they can't keep the doors open any other way. They think they have to have the money for that, okay, because they just can't survive without it, okay. Finally, this is the last. If you're not gonna use it for if you're not gonna use this system, if you're not going to use OneCare for the system for which it was devised, okay, then what you've got is this a wild, huge, bureaucratic, crazy system. All this stuff, it includes this OneCare, not OneCare, this includes the AHEAD system, okay, is having failed in 10 years to ever even use the all-payer model. Then now we're going to go into another 10-year program that is also going to just run into this problem that nobody is willing to get their hands around what's really going on in the delivery system on the ground. What we could save by shifting reimbursement is a full third. 4.3 trillion in the United States. You just take a third of that and you could cut it off. It would take 4 or 5 years, but it would be a lot of money. And in Vermont, you could cut $300 to $500 million a year out of your system if you had any stomach, okay, for dealing with the real problems are. Anyway, thank you. I went over 45 seconds. I'm sorry, Mr. Chairman.
I got you 2 minutes over, Mr. Davis. I had you going to 11:22. I got you at 11:25.
I apologize for that, sir. That actually, the reason is I really didn't do that deliberately. I just forgot to start the damn watch.
No, that's okay.
You are right about that.
I appreciate the comments, and I thought they were really helpful. So thank you for taking the time, because it's valuable. A lot of really good points there. One I did want to point out and respond to, because I think you've mentioned a couple times. I don't know exactly the phrase, but the political blowback on the 14 hospitals and the footprint of our hospital system is something that you've raised a couple times. And I did just want to flag the work that Oliver Wyman is doing and the set of recommendations on transformation that will be coming out, and a long series of meetings with communities on this exact topic. Those recommendations are going to be shared with hospitals, I think the week of June 10th-ish, and then in health service areas around July, a couple weeks after that. And then in terms of like the political blowback and all that, the transformation work that's coming out of that is being led by the Agency of Human Services. So they, not the Care Board, are really the folks, if you have feedback you want to provide on this issue, they're going to be leading the transformation work that comes out of that Oliver Wyman report and effort. It would be great. I would love for you to attend, if you're able, some of the health service area meetings and get me your feedback on this topic. So thanks for raising that. I just wanted to kind of give you some dates and background, and our staff can send you specific dates and information if it's helpful. Mr. Peiss from the Healthcare Advocate.
Good morning. Just wanted to thank Michelle, the board, and OneCare for the conversation today. Just briefly on the guidance, we support the guidance. I think it's a thoughtful, reasonable recalibration is really the word that comes to mind for me. I also agree with I think the intent of the conversation around broadening the language that was discussed, the introductory language to the guidance. I would suggest that maybe revising or consider revising something to say ask OneCare to demonstrate that it's minimized costs, so that and then provide the burden on the regulated entity, as I think is always a part of the board rules, and require OneCare to demonstrate evidence that the programs are of benefit to Vermonters. And I agree. I think that can be financial. I also think, to remember Lunge's point, that can include quality. And I think if I can go back briefly on the amendment conversation, I just had a question and a comment. And we don't have to pull up the motion language, but I just want to leave the board with a couple thoughts from our office on that. I wonder if the motions that are being contemplated, the two motions, if they're mutually exclusive? Meaning, could both of them happen at the same time if the board believes that both could be required to obligate OneCare to perform what the board intends? And I think on the primary care language discussion, I think for us, it's most important that the language is clear and explicit. I think something around saying directly support primary care providers would be more warranted, because I just would worry about language being squishy. So just a couple thoughts there. Thank you.
Thank you. Okay, I think that's all we have on the agenda today, and thank you everyone for attending and for the conversation. Is there any old or new business for the board? Okay, and I will move that we adjourn and we take up these potential motions on the ACO work, hopefully next week. Is there a second to adjourn?
Second.
All in favor, say aye.
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 Aye. Thank you, everyone, and we'll see others at 1 o'clock, and have a nice lunch. Adjourned.